Okay, well, we're just at about 5 after 12 Eastern time, so I think we'll get started. As people come in, we'll add them in. I will start by sharing my screen. Thank you all for joining us. This is our first webinar of 2022, as well as it is our first Sepsis Canada Summit series. Throughout this series, our research teams are going to be providing an overview as well as progress to date on their current network projects. We'll take about 5 minutes for quick introductions, housekeeping items, and following these, we'll begin the presentation. Please feel free to ask questions throughout the webinar today via the chat box. Allan has also mentioned that during his talk today, you may ask questions during his presentation. And what I'll ask you to do is if you can just use the raise hand function, we will unmute you and then you can ask your question either through the chat box or you can verbally ask your question. During the presentation, all microphones will be muted. And again, if you wish to ask a question at the end of the presentation, please feel free to raise your hand and we'll enable your microphone to be unmuted. Lastly, this meeting will be recorded and we will be publishing it on our website as in the resource section for those who were not able to attend this session today. Before we go any further, I would like to acknowledge the Indigenous peoples of all the lands that we are on today. While we meet on a virtual platform, I would like to take a moment to acknowledge the importance of the land which we call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all Inuit, Métis, and First Nations people that call this land home. Who is Sepsis Canada? In 2017, the World Health Organization resolution identified sepsis as a global health priority, urging member states and the WHO Director General to take specific actions to reduce the burden of sepsis through improved prevention, diagnosis, and management. In response to this resolution, the Canadian Institutes of Health Research, CIHR, funded Sepsis Canada, a single nationally coordinated research network to further understand the causes and improve the prevention, detection, and management of sepsis. Our network brings together experts from different disciplines working collaboratively on various interrelated projects under an integrated and unified program of research. Sepsis Canada has created 3 teams within our network. And throughout the Sepsis Canada Summit series, you will have a chance to hear from all 3 teams, which will include updates on their current projects, progress to date, and their next steps. And with that, I would like to introduce you to our first speaker in our series. From Team 1, Dr. Allan Garland. Team 1 Population Health, Economics, and Policies projects include diabetes metabolism, scoping review of sepsis knowledge, economic analysis of sepsis, incidence of sepsis, Catalogue sepsis databases. Allan Garland received a BS, Bachelor of Science from the University of Michigan, and a Master of Arts from Harvard University. He completed his MD Internal Medicine residency and research clinical fellowship in pulmonary and critical care medicine at the University of Chicago, in faculty positions at Robert Wood Johnson Medical School in New Jersey and Case Western Reserve University School of Medicine in Ohio. He was the director of their medical intensive care units. He came to the University of Manitoba in 2007, where he is Professor of Medicine and Community Health Sciences, adjunct scientist at the Manitoba Center for Health Policy, and since 2012, he has been co-head of critical care medicine. I will now turn it over to Dr. Garland to share his screen and begin his presentation.
Thank you, Christine. I'll just make one correction. As of February of 2021, I am no longer co-head of the section of critical care medicine here.
Oh, sorry.
Okay. All right. So can we see this? Do we see my slides? Okay. All right, so thank you for that introduction. As Christine said, I only have about 30 minutes of slides to go through. So I invite people to, it's okay to interrupt and ask questions, especially since it's a bit of a challenge to give a talk to a group, a mixed group of people that include technical experts and people who are not technical experts. So if I got it wrong and there's too much technical detail and it's not clear what that means and people want to know, feel free to interrupt. Okay, so team one, the steering committee of team one is shown here. So myself and Kidnapa Tavorn, who's at the University of Ottawa, are the co-heads of this group. Okay, so a little bit of background. Epidemiology, just so everyone's on the same page, is the study of health in populations. And despite being first described actually thousands of years ago and being intensely studied in the modern era, there's surprisingly little that's really clear about the epidemiology of sepsis. Even simple things like, does it occur more frequently in men or women? Things like that are topics of epidemiology. So there's a major uncertainty about how frequent sepsis is. As you heard, the World Health Organization and a variety of other organizations recognize that sepsis is a very important and not uncommon health problem in the world. But exactly how frequently it occurs is not entirely clear. And there's a lot of reasons for this. We'll talk about some of them presently. Despite the evidence of it being common, we still think that we may underestimate how often it occurs by 2- or 4-fold in developed countries, and even more so in lower and middle income countries. Now, what is sepsis? Sepsis is not a disease in the same way that diabetes is a disease. We know what causes diabetes. We have a test for diabetes. It's a disease. On the other hand, sepsis is a syndrome, which means it's an entity, a health entity, that's defined. And the basic definition has always been something like this. It is organ failure caused by severe infection. However, within that large definition, there have been 3 different specific definitions over the last 25 years. Those have been called sepsis 1, 2, and 3, and we're currently working on the sepsis 3 clinical definition. But the very fact that its definition has changed over time is one important indicator that we're not 100% sure what it is and how to identify it. Clinicians at the bedside in the intensive care unit, so I'm an intensive care unit physician, we sometimes struggle to identify it. And one of the reasons is one of the 2 requirements that you have an infection. There's lots of people in intensive care units who have infection, but there's lots of things that look like infection that aren't. The main way we identify an infection is people have a fever, a white blood cell count, a source of infection like infection in the lung, pneumonia. But in fact, there's many things that can mimic infection in critically ill patients. And we may be wrong about infection when we say that patients have infection. We may be wrong up to 40% of the time. So here's the things that we would really like to have and that the team one is going to work on in terms of infrastructure for sepsis. I should take a diverge here for a moment and mention that the sepsis network is not the funding for the sepsis network by the Canadian Institute for Health Research is not like most other research projects that are funded by CIHR. Most projects are to answer a specific question and to increase our knowledge in a specific way. The network grants, of which this is one of those, are really intended to create infrastructure that will help all researchers in the area advance their own research. So most of, not all of what I'm going to talk to you about, but most of it is about projects whose goal is to make it easier for others to do research in sepsis. So what is currently known about the sepsis in populations, the epidemiology of sepsis. Well, what do we need to know about it? Well, the current knowledge is scattered, sometimes inconsistent. I gave you an example before. You will find publications, scientific publications, that say that it's more common in men and women, that it's more common in women than men, that it's equally common in men and women, and the same for most aspects of what sepsis, how sepsis manifests in populations. So the data is scattered and inconsistent. It would be nice to have a real good summary of what the data is, whether it's consistent and inconsistent. Second is the data for studying the sepsis in populations. There are lots of data sets that could be used, but they are spread all across the country. Some of them are not well known by the people who study sepsis, and I'll give you some examples soon. Next is, even at the bedside, it is, as I mentioned, hard to be sure that this patient or that patient has sepsis, as opposed to something else that might mimic it, okay? And when you're looking not at the bedside at a given patient, but you're trying to look at databases like provincial or national databases that identify whether somebody really had sepsis, it's even harder. And so this quote I have here, we desperately need better tools for sepsis diagnosis and surveillance. So these are the things that we addressed, that we are going to address and have started addressing within the infrastructure portion of Team 1. So the first project will address the need A that I just mentioned. And this is to identify, summarize, and catalog everything that's known about sepsis knowledge. The person leading this is Dr. Elizabeth Wilcox, who's at the University of Toronto. So what Liz and her working group will do is perform widespread, what are called scoping reviews. They will review extensively the literature that's out there, the scientific medical literature that's out there, and clarify what we know and what we don't know about what? About the risk factors for sepsis. So for instance, is gender, one gender or another risk factor for sepsis? How it varies across the country. Is it more common in urban or rural areas? So some diseases actually vary by your latitude. Multiple sclerosis is an example that varies by latitude. So does sepsis have something like that? We don't know. These reviews will also look at the short-term and long-term outcomes, and those include clinical outcomes, how people do in the short term, do they survive, whether they're able to go home, how they function after survival, how their brain works after survival, and then the economic consequences for the individuals who have sepsis and also for society. And we intend to do this separately for adults, children, and neonates. Okay. And what are we going to do with all this information once collected? Well, we're going to put it into an open, indexed, and searchable electronic repository that everybody in the world can look at. So what good will this be? Well, I'll give you an example. Let's say a researcher is been doing some of their own local work, and they're interested in some aspect of the population relationships of sepsis. But they don't know how well that's been studied and what's already known. And it can take many weeks to figure that out, to do your own evaluation. So that person could log into this electronic repository and they could see where the gaps in knowledge are. And they could therefore fine tune their clinical research, their research question based on what's already known. Now, one of the issues with creating such a catalog is that 5 years later, it doesn't have the last 5 years worth of data. So we will seek future funding to try to keep it current, to update it. The biggest problem, of course, the most work is to create it from the outset. The next need is to address, to understand and identify and catalog all the databases in the country that could be used to study the epidemiology of sepsis. So I lead this along with Isabelle Fortier. Isabelle is a faculty member at McGill University. There are lots of existing databases that could be used of all types. So administrative data refers to data usually collected by governments to administer the healthcare system. So not only do the provincial governments all have extensive administrative data. For example, they have a database called the Discharge Abstract Database that contains information about every hospital admission. That's an administrative database. Another one is called NACRS, and NACRS contains information about all outpatient visits of patients to doctors, nurse practitioners, nurses, things like that. So that's a big category of important databases because they exist provincially and nationally throughout the country. Clinical databases are databases that are made to collect more detailed information about a clinical problem. So 5 jurisdictions in Canada have clinical intensive care unit databases where every person admitted to an intensive care unit is recorded and a lot of detail is collected there. More clinical detail than there would be in administrative databases. Then there's laboratory databases. Whenever we go and get a laboratory test, inpatient or outpatient, in hospitals or out of hospitals, that information is collected in a laboratory database. Some of the provinces have universal medication database, outpatient prescriptions. Manitoba is one of those. Saskatchewan is another one that has information about every prescription that is filled by pharmacies. And then there's population-based surveys. I'll talk more about them. But using existing data, about which there is tons of it across the country, means that you have to know that a database exists. You have to know how to access it, and you have to be able to link it with other databases that make it more powerful. So this I already said. So what we're going to do for this sub-project is we're going to create what's called a metadata catalog. A metadata catalog is a way to document data about the data. So it's not that we collect the information about the individual patients. What we collect is information about the databases. So for instance, the Discharge Abstract Database that's available nationally and available in each province. What does it contain? What information does it contain? That's the metadata about the Discharge Abstract Database. And so what we intend to do is create at McGill, actually, through a company called Maelstrom Research, we're going to create a metadata catalog that's searchable, that you can search about. So you want to know, for instance, here's an example. I would like to know about Canadian databases that contain systematic information about people's diets. There are some databases that contain that information, but they're not very well known outside of specific categories of researchers. So if you wanted to study, for instance, what would you need if you wanted to know about the impact of vegetable intake in people's diets on the probability of getting sepsis? Well, where do I get that information? Well, I could get the information about sepsis from the Discharge Abstract Database. Since sepsis is a severe illness, virtually everybody with sepsis is admitted to a hospital. So the Discharge Abstract Database has information about all hospitalizations. Okay, that's fine. But where the heck would I get information about systematic information about vegetable intake on some subset of Canadians? Well, there are databases that ask that information. But most people don't know about those databases. A good example is the Canadian Community Health Survey. And so if you were interested in studying the impact of vegetable intake in diet on the risk of sepsis, and you got your hands on the Canadian Community Health Survey and merged it with the Discharge Abstract Database, you could probably answer that question. But you have to know where that information exists. And the metadata catalog's aim, its goal, is to make a searchable catalog where if you wanted to know what databases in Canada, if any databases, and which databases would have the information I want to answer the clinical or the research question that I want. Not only where it is, but who do I talk to try to get my hands on that data, for instance. Okay, so that's what a metadata catalog is. Okay, so as I said, we're going to work with Maelstrom Research to create a metadata catalog of medical and non-medical data containing a broad spectrum of information that could be used by researchers and policymakers to try to answer important questions about the public health aspects of sepsis, the epidemiology of sepsis. So we'll assist identifying databases. For instance, I said administrative, the discharge abstract database. There's I've told you about NACRS, which is a database of outpatient medical contacts. There is a national home care database that the Canadian Institute for Health Information collects information from every province, most provinces, on everybody in home care. Similarly, there's a national long-term care database that contains lots of information about people in long-term care. There's a cancer registry. And then provinces have additional data. Some provinces, as I mentioned, have really valuable outpatient prescription data. There is provincial data on things like education, justice, social housing, income assistance, immigration. And interesting questions that haven't been answered is there a strong relationship between education level and the risk of sepsis? How about the risk for immigrants? Does that risk change in the period after they immigrate and now have been living in Canada a longer time? These are all worthwhile questions, but you need to combine databases in order to answer them, and you need to know about the databases before you can even start answering them. As I mentioned, there is clinical, highly detailed ICU data in 5 provinces. We intend to collect that in our metadata catalog. Again, not the data itself, data about the databases, what's called the metadata. The Canadian census has all sorts of great information. It's at the level of postal codes, but it includes things like socioeconomic status. It is well known that things like socioeconomic status fit into the category of social determinants of health. People of lower socioeconomic status have more chronic diseases, more acute health problems, and so these are important things to be able to take account of. And the census, which is done every 10 years, includes a lot of great information that helps with evaluating these parameters. And then there's national survey data that I'm going to talk about next. Now, in addition, Canada is a country that has done a lot of specific research projects, randomized controlled trials of therapies, for instance, in a variety of health situations, including sepsis. And so we intend to include information about those data sets in our metadata catalog as well. And I'll talk about the Canadian Health and Taxation Database presently. Okay, so these surveys, like the Canadian Community Health Survey, they work like this. Households are invited to participate, and they participate for 3 years in a row, and then they go off and another household is asked to participate. And so Statistics Canada, which runs most of these rolling surveys, at any one time, there might be 50,000 households in the whole country that are participating. But since it's rolling and 3 years later, it's another different 50,000, over time, there's a lot of data in this. How does the data get acquired? Surveys. A household that agrees to participate in the Canadian Community Health Survey agrees to every year for those 3 years fill out a very extensive survey about everybody in the household, including their diets, their health problems, their medications, their health habits, all sorts of things. And this is these are rich sources of information. Their real value is to merge them with medical data identifying sepsis, like the hospitalization data, to assess novel determinants of sepsis and its outcomes. Okay. The third part is identifying how frequent sepsis is in our populations. I lead this along with Hallie Prescott, who's a faculty member at the University of Michigan. There are currently 2 approaches used for identifying, not at the bedside. We're not talking about identifying a patient when you're if I'm clinically taking care of patients in the intensive care unit, we're talking about using existing data sets like administrative data to identify people with sepsis, to understand what fraction of the population gets sepsis each year. Is it more common in women or men? How does it vary with age, et cetera? Okay, so there are two existing approaches that we're going to fine tune and improve, plus we're going to develop a new approach. And we're going to contrast and compare the rates of sepsis and their characteristics and outcomes of people with sepsis across these three methods. And we're going to do it separately for adults, children, and neonates. So the first uses the discharge abstract database. The discharge abstract database for everybody admitted to a hospital in Canada contains all sorts of codes, information about their diagnoses and what care they get. So for instance, their diagnoses include a whole host of diagnoses that can represent infection. For instance, there's a code for bacterial pneumonia, infection in the lung. There's also codes that represent kidney failure or problems breathing, in other words, organ dysfunction. And so the concept here, and this was first created back in 2001 by Derek Angus, who's at the University of Pittsburgh, was if you identify a person whose codes in the discharge abstract database identify the presence of an infection and the presence of an organ that failed, like the kidneys, then that likely represents somebody with sepsis. Not necessarily, but likely. So this is the first approach. But there have been multiple incarnations of trying to do this, which use different codes. Their performance varies widely. And not only that, but if you apply the same rules over time, it looks like in some cases that the incidence of sepsis, the rate of which people in the population get sepsis, is going up quickly. And that may or may not be true. The second method uses another set of data that exists in hospital settings. And this was created by the United States Center for Disease Control. It's called the Adult Sepsis Episode Methodology. It also attempts to identify people in the hospital who have an infection and an organ that doesn't work, one or more organs that don't work. But instead of using the medical charts, it uses the electronic medical record that increasingly hospitals are implementing. In fact, Alberta is implementing an electronic medical record system, the same one in all of its hospitals and all of its outpatient practices. They're spending $750 million to do that, but they think that that implementing this will make their medical care much more cogent, comprehensive, coherent, and uniform. Anyway, electronic medical records contain all sorts of information. They contain information, for instance, about whether you've had, whether you have a fever or an elevated white blood cell count that's common in infection. And so you can use the information from electronic medical records to identify infections and to identify whether the organs are working or not. How do you do that? Well, they contain information, for instance, about whether people get kidney dialysis. Kidney dialysis is used in kidney failure. So if somebody in their electronic medical record starts getting dialysis, that would indicate that their kidneys failed. And so that's one approach. These are the two basic approaches that have been used to identify sepsis in existing data for people who've been in hospital or been in an intensive care unit. They both, however, begin with an assumption that with a underlying basis concept that sepsis is an infection and an organ failure. Okay. What we intend to do is to refine these algorithms. We're going to do it in 3 jurisdictions, Calgary, Ottawa, and the eastern townships of Sherbrooke, Quebec. And we're going to use hospital, ICU, and emergency department information from these. I won't go through this in great detail. This is technical stuff that honestly at this level is not that interesting, but we're going to look at all the codes for infections that occur in these databases and all the codes that represent organ failure. And we're going to fine tune them to try to get the best combination of codes to identify people with sepsis. Okay. All right, so this is how we're going to do that. For instance, just today I got from our friends at Canadian Institute for Health Information the list of 1,700 and some codes that are used in hospital records to identify infection. Okay. And we're going to do something similar with the information that comes from the electronic medical records. Okay, now, again, both of these start with an idea of what sepsis is, and then tries to identify people who have it, who have those things. But call that the forwards approach. We're going to try to take a different approach for the third method of identifying sepsis. We're going to take everybody who comes into the hospital and everybody who comes into the intensive care unit. We're going to collect all the data about them, and we're going to apply to that mass of data sophisticated statistical methods to find what might call clusters of patients with similar characteristics and similar medical problems. Okay. And then these are some of the names of the statistical approaches we're going to mobilize to try to do this. And the variables include everything we know about them. Okay, their chronic problems, their socio-demographics, which like the age and sex and gender and socioeconomic status. It's going to include the types and characteristics of their acute illnesses and how they do in the hospital. Okay, and then what we expect is that these sophisticated statistical analyses will generate subgroups, clusters of people with similar characteristics. And then our groups of clinical experts are going to look at these groups and see if they represent people along what we imagine the spectrum of sepsis would be. So let me give you an example of that, because that's a pretty vague comment. We usually identify sepsis in the intensive care unit, infection plus organ failure. But the truth is, there's almost certainly people with sepsis who are on the regular wards, because if their organ failure doesn't require advanced life support, if they have breathing problems, but it doesn't get bad enough to need artificial mechanical ventilation, or they have kidney problems, but it doesn't advance enough to need kidney dialysis, then they would probably stay on the regular ward. And we do a much worse job identifying people, let's call that mild sepsis, than we do identifying people with severe sepsis. So we think that this generalized approach might do better and help us better identify subgroups along the full range of heterogeneity of what sepsis actually is in the population. Okay. So what we hope this will do is give us more accurate measurement of the rates of sepsis in society, more effective identification of sepsis for studies, for research studies, a better understanding of the clinical range of sepsis derived from that last approach that I just mentioned. And we're going to make the code necessary for doing these analyses publicly available so people in other countries can use them. Okay, so those are the infrastructure problem, the infrastructure projects, sub-projects that Team 1 is doing. There are two other projects that I want to talk about, but I'm going to stop for a moment because it's only 11:38 and I only have 5 minutes of stuff to tell you about the other projects. I'm going to stop sharing and see if anyone has questions about those three, call them infrastructure projects that I've already mentioned and gone over in a little bit of detail. Any questions, anybody? Feel free to ask them. You can put them in the chat or you can raise your hand and somebody will unmute you. Nothing. Okay.
Are
so
sepsis bundles?
I'm sorry.
Are sepsis bundles included? Because I understood that there were sepsis bundles in the hospitals to help identify sepsis. Is that information included in your database? Like, will it help with the bundles, or are sepsis bundles just a name for something that's already included in your checklist of?
It's a good question. Sepsis bundles are a group of management treatments, call them, that are used in people who are believed to have sepsis. Now, to the extent that, as I mentioned before, there's probably many people who have sepsis in the hospital who aren't identified as having sepsis. And there's people who are identified as having sepsis who in fact don't have sepsis. While we're interested in the treatments for sepsis, I wouldn't say that application of a sepsis bundle per se is the best way to go in identifying sepsis. We need to go upstream from there before a sepsis bundle has been implemented, because again, it's used on people who they believe have sepsis. We want to try to figure it out upstream from that point. And also, Christine, most data does not include information of, to that level of detail about the application of sepsis bundles. But thank you for the question.
Thank you.
Other questions? Okay, there seems to be a chat. Let's see, what's that say? All right, so I'm gonna continue. I'm gonna share again and show the last few slides. Okay. Okay, so I'll make this full size. Okay, so there's two other main projects. First is an economic assessment of the consequences of sepsis. Okay, this is led by Callie Barrett, who's at the University of Toronto, and Kidnapa Tavorn, who's at the University of Ottawa. And there's two sub-projects within this. So first of all, what are the economic consequences of sepsis for the people who get sepsis and survive, and also for society? Well, this is not very well known, and we want to add to the knowledge about this. So there's two sub-projects. The first is to ask the following question. Amongst working age people who were working at the time that they got sepsis, what is their, and they survive, they have long-term survival from their sepsis. Do they, what is their ability to work and earn in the long term? Okay, so we created a database at Statistics Canada called the Canadian Hospitalization and Taxation Database. It links the information nationally about all hospital care and about individual tax returns. And it lets us identify, for instance, people who were working. How do we know that somebody's working? Well, their tax return tells us if they were working and making money. And we can therefore look at people the year before they got sepsis and say 3 years after their sepsis and see if they're still working or not. And if they are working full-time or part-time? Is their income gone up, gone down, stayed the same as it was before their sepsis? So this is at the individual level. So in other words, what we will look at is among working age people who develop sepsis and are long-term survivors, by which we define as 3 years, we will evaluate their ability to work and earn compared to people who were very similar to them, the same age, the same sex, the same marital status, living in the same province, etc., who didn't develop sepsis. And by that, we can figure out the effects on the individual's ability to work and earn. We've already done exactly this kind of analysis for other acute medical problems. We've done it and published this for people with heart attacks, strokes, and also people who had severe trauma. So that's the first sub-project. The second sub-project asks a different kind of question. It's more on a societal level. So it's been known for a long time that a small fraction of the population consume a large fraction of total healthcare resources. And those people, as you could imagine, are of great interest to policymakers and politicians. And so these are called high-cost medical users. And so what's not known, and what we're going to answer in this analysis using data from Ontario, is we're going to answer the question of whether people who develop sepsis and then survive their sepsis, whether their sepsis turns them into high-cost medical users. Obviously, we know already that many people who survive critical illnesses of all types, including sepsis, develop long-term problems with medical problems. So what you've heard about most recently is long COVID. Long COVID is just a set of functional, medical, and psychological problems that occur in people who survive COVID. Well, those problems have impact on people's use of the medical system subsequently. So what Callie and Kednep are going to do is use the Ontario data and basically see if sepsis, how frequently really, sepsis turns people into high-cost users of medical resources. The last project is led by Claudio Martin and Damon Scales, and this is about diabetes and sepsis. Why would there be a link between diabetes and sepsis? Here's why. Diabetes, through the high blood sugar, affects your immune system in the short term and especially in the long term. It affects the ability of the immune system to fight infection, and people with diabetes have higher rates of infection than other people. Therefore, they probably have higher rates of sepsis, which is ultimately caused by infection. And although there is some evidence of this, it is not clear-cut. So Claudio and Damon and their co-workers are going to again use data from Ontario. We often use Ontario data not only because it's the biggest province, but because it has great administrative data at what's called ISIS. I can't exactly remember now what all the letters of ISIS stand for, but it's a repository of health data in Ontario. So they are going to identify diabetes with a definition. Those definitions are things like they were hospitalized for diabetes at least once, or they went to the doctor for a diabetes problem at least 2 times in the last 3 years. Those are the kinds of administrative definitions that help us from not clinically, but from at the population level, identify individuals with diabetes. Then they're going to evaluate amongst those people with diabetes compared to people without diabetes, how often they develop sepsis, taking into account age and sex and socioeconomic status and the infection type and their diabetic treatments. And this is a really interesting one, whether people with better control of their blood sugar have less sepsis than diabetics with poorer control of their blood sugar. It would make sense that it would, but we don't know that with certainty. And amongst those with sepsis, they're going to evaluate how diabetes mellitus, DM, and obesity, which often coexist, influence the pattern of sepsis, which organs fail, whether people live or die, and other outcomes. Okay, so I'm going to stop sharing. Those are the other 2 projects. So we have at least 13 minutes if people have questions. I'm happy to answer any questions about any of this stuff, especially the stuff specifically about the research projects, of which I've gone over all of them now, for Team 1, the population health pillar of the Canadian Sepsis Network. Questions? Everybody, so remember, I know that you're all muted. You can either raise your hand and you can get unmuted, or you can put a question in the chat, which I'm looking at right now. Okay, it seems like there's no questions. Christine, do you have anything else to say? Or Nubia?
I do, yeah. I have one last little blurb, I guess. Our next webinar. Well, first I want to thank everyone for joining us. And of course, Dr. Garland for coming to present today on Team 1's current projects and progress to date. Very, very informative. Our next webinar is February 17th from 12 p.m. Eastern Time to 1 p.m. Eastern Time, where we'll have Dr. Gina Parsons-Lee from Team 2, Advocacy, Knowledge Transfer, and Education, who will update us on their projects, on their progress with their project, creating a culture of sepsis awareness through advocacy, health literacy, and knowledge transfer. And I'm going to put the link to that registration in the chat box right now. For you guys, you can actually click it and register now, but we'll also be putting that out on our social media channels. You can sign up for our newsletter through our website. And that's at sepsiscanada.ca. And once again, I just want to thank everyone for coming today. Rebecca has her hand up. You can unmute yourself actually right now. So you can put your hand up.
Yeah, am I unmuted? Sorry, I was
You
just,
are unmuted, yeah.
Thank you, Dr. Garland. I think I was just mainly thinking about your presentation because there was so much there. And I think I became overwhelmed at the magnitude of work, seemingly with all the databases. I'm always fascinated about the idea of creating the meta database. And I guess I'm just wondering from your perspective and your experience in this so far of what kind of barriers you anticipate, particularly with the linkages of the different databases that you've identified and on a national scope. I think this work is so valuable, and as a researcher, incredibly valuable, both in terms of the kinds of data that can be collected and applied for public health needs.
So thank you for that question. I agree that it's a very powerful tool that should help present and future sepsis researchers. Remember, we're not collecting the data itself in the catalog. We're only collecting information about the databases. An individual researcher who wants to identify where the data exists that he or she is looking for can go to the metadata catalog and identify, for instance, to use my previous example, oh, the Canadian Community Health Survey has information about dietary patterns. Well, that's Statistics Canada. And the Discharge Abstract Database has information that will help me identify people with sepsis. So I could put those together, but I have to go to the people who own them. So I'd have to go to make contact with Statistics Canada, and I'd have to make contact with the Canadian Institute for Health Information to seek the data itself and see if I can put them together. That is the burden of the individual researchers. What we're trying to do is just make it easier for them to do that. So our metadata catalog would tell them, for instance, for those two databases, here's this person that you contact to try to get this database to actually get the data itself. That's a continuing challenge. And it's always been a challenge, especially across jurisdictions. So for instance, most provinces are not willing to let their data leave their province. So if you have a database in one province and a database in another province, you can't easily put them together. You have to do the analyses separately and then combine the analyses afterwards. So in direct answer to your question, our metadata catalog is going to give them a leg up on identifying where the databases are and who to talk to get the actual data. But it doesn't contain the actual data, and therefore it doesn't contain linkages between the data sets. Did that answer your question?
Yeah, thanks very much.
I see Peter Dodek from the University of British Columbia has a question that I will let. I will let Christine and Nubia answer. How will the network publicize the findings to the broader world of sepsis researchers? So guys, do you want to handle that?
Yeah, that's a great question, Peter. And essentially what we plan to do is initially allow the team leads to present on the projects that are actually funded by Sepsis Canada. And then once we've gone through those presentations, we're going to open it up to the broader network and make this more of like a talk for the entire network to be able to share the different projects that they're working on related to sepsis.
Okay, thank you. Were there, I'm just looking here, it doesn't look, there will be a portal. Most of the other things that are on the chat are things from Nubia in partial response to that. Does anyone else have any other questions for me or for anybody on the line? Okay. Christine or Nubia, any last things, any real last things you want to say?